Now, may I please call upon Dr. Sangeetha Menon once again to talk on the topic short cervix, how to, and what if.
I'm here for the next 20 minutes as well to talk on the short cervix. What I really am going to touch on is what really is short. Very important how you're going to measure the length. Who needs a cervical length surveillance? Are you going to use progesterone or a cerclage for the short cervix? Which stitch would you put if you needed to put one? Are we going to stop putting in stitches at 23 weeks? What happens between 23 and 28? What is our stand or everyone's stand on emergency cerclages? And what kind of tocolytics will we use, if at all we use? So traditionally we have been teaching and we follow that a cervix from external to internal loss, which is less than 2.5, is short. There are studies that tell you that if it is a twin, you may take 1.5, but that really has not come into vogue. But remember, with the previous preterm birth, she runs the risk of almost twice, that is, 2 times more chance of landing in a preterm birth this time as well. And the relative risk, that means 6 times more chance if the cervix is less than 2.5. So, very imperative that we measure that cervix correctly. It cannot be on a trans-abdominal ultrasound. It has to be with a TVS. The bladder must be empty because even a partially full bladder will press on the cervix, either elongating it and sometimes making it shorter as well. On a sagittal view, you measure exactly, and it's very easily done from the external loss to the internal loss. It's good if you have a 16-week uterus to gently push down that uterus and see if the cervix is funneling. But funneling is not to be taken into account if the cervical length is more than 2.5 centimeters. Now, having said that, if it funnels, we are worried. Many of the things that I'm going to say today, or rather elucidate in the next few slides, may not always be applicable. So, if you have a 2.5 centimeter cervix and it is funneling, everybody, you may not put in a stitch, but you look at that cervix a little bit more carefully. So, absolute cervical length is the only criterion, and routine surveillance for everybody is not recommended. It's a controversial subject because can you imagine every anomaly scan putting the patient and doing a vaginal scan as well? Is it cost effective? Quality assurance. Any and everybody could do a cervical length. Are you going to get the same measurements? Unnecessary interventions will increase, and if at all you're doing it, it must be a TVS by a trained sonographer. Now, there is a care bundle that is applicable for cervical incompetence, in which it's called Saving Babies' Lives, and they have actually divided the risk factors into high risk factors and moderate risk factors. So, if you have a previous preterm birth or a previous loss in the second trimester, it is all high risk. Previous PPROM less than 34 weeks is high risk. Non uterine variant, that is a Mullerian abnormality but not a biconvate uterus or a small arcuate uterus. Those don't have cervical incompetence. If you have a uniconvate uterus or a didelphys, you may think it is a high risk factor. Previous cerclage or an intrauterine adhesion, previous trachelectomy, and these are the kind of women who need to be screened from 16 weeks. Sometimes, maybe even at 14 weeks, but remember that it's the lower uterine segment versus the internal loss really starts unfolding only by about 16 weeks. So, getting an internal loss clearly and measuring a clear cervical length may not really be possible before 16 weeks. Intermediate risks. Very, very interesting to learn that a previous full dilatation cesarean section is an intermediate risk for an incompetent cervix. And if you've done any excision procedure, multiple 1 centimeter or deep leap excisions on this or a cone biopsy of the cervix, puts her at an intermediate risk. But if she has an intermediate risk, they need a single screen only between 18 to 20 weeks. The presumption is that if that pregnancy is able to be within the uterus with a tight internal loss and a long cervix between 18 to 22 weeks, it is unlikely to open up after that, just because of a dilatation of a cervix which was done at full dilatation later, or because of a LEAP procedure. Very important to note and very significant to note that there are some very high risk associations with cervical incompetence. That is, a PCOS has an increased incidence of cervical incompetence, but nowhere does it tell you that all the PCOS that you see, you're going to screen the cervical length. But it is there, it exists. And there is definitely an increase with obesity, and that is postulated to be because of in both obesity and cervical incompetence, there is a heightened inflammatory response. Now, what really causes a cervix to open up, nobody knows. It opens up in one pregnancy, it doesn't open up in the other, in spite of the fact that both were average weight babies and both were singletons. So, inflammatory response is postulated to be one of the factors. There was a time when we looked at prophylactic cerclages, but now those terminologies have gone. We use a history indicated cerclage when you've had remember, three or more second trimester losses or preterm births. And here we put in a stitch for them when they've had 3 or more early enough. So after the aneuploidy screen, everything is done. You don't need to look at their cervical length. The history is telling you that you need to put in a stitch. So aneuploidy screen, baby is okay, low risk, put in the stitch. The ultrasound indicated cerclages will come a little bit later. That is when there is one preterm birth or one previous PPROM. The 3 is not there, but still you're worried. You start looking at the cervix serially, and if it shortens below 2.5, you put in the stitch, but there you can start putting it in maybe a little bit later. But the books will tell you, and all the guidelines will tell you that you don't put in a stitch after 23-24 weeks, because by then the baby is viable. You can get the baby out. Your neonatal nursery can take charge of it. Are all our neonatal nurseries capable of looking at 23 weekers? Are we worried about the kind of babies we will put forth into the population at 23 weeks? So I will admit point blank that I will put in a stitch if I feel the cervix is short, or there is a history plus cervical length being short at 25 weeks, I'll put it in. I may not put it in after 28, 30 weeks. No. But at 25, 26 weeks, yeah, I may just put it in. So that is something that you need to think about. But remember that 40 to 70% of the women whom you feel that there is a problem, they've had a previous preterm birth, they've had a previous whatever may be the risk factor, and you're looking at their cervixes remain long enough. They really don't go in. So 70% of the time you are quite safe. But what are the definite no's for a cerclage? Don't put them for all multiples. Do not put them for all ART pregnancies. Previous 3, 4, 2, 6 first trimester losses, it's not an indication for a cerclage. Previous trachelectomy, conization, LEAP, they are indications to follow up the cervix, but not to put in a stitch. Any previous stitch needs to be followed up, doesn't need to have another stitch. Uterine anomaly needs to be followed up, not straight away. And this is something that we are all always faced with. Incidentally, short cervix, gravid, singleton pregnancy, no suspicious history. What should I do? They say no. The largest study was by Toe et al., and he looked at large numbers, 47,000 women. So you really can believe what he has put forth. And out of which only 470, which is less than 1%, had a short cervix. He took 1.5 centimeters. Out of that 470, 253 only agreed to participate. And he compared the classical Shirod curve with expectant management. And he said that preterm birth in these incidentally short services, they delivered at less than 33 weeks in both the categories in the same way. 22% in the cerclage and 26% in the expectant group. So really putting in a stitch for a primey just because of a short cervix is really not. But you always wonder, the patient will have 10 other consultations and she'll ask you, can't you put in a stitch? Do I need to use progesterone? Progesterone today is also not really recommended, but very many of us will give that progesterone because basically we really don't know what else to do. Stop It 2 came out in 2021, and I'm quite sure that many centers in Chennai, I think one center, two centers in Chennai were part of this study, the RCT on the Arabian pessary to prevent incompetence in the twin with the short cervix. Here they took the cervix as 3.5 centimeters and they really didn't show any benefit at all. But there are people who swear by the Arabian pessary. But I have never used it. I've only seen pictures of it, but there's no experience. So why are we so hesitant? Can't we just put in that stitch? Why are we talking so much about it? So morbidity from a cerclage, we believe, is profound. But studies have said that there's not really so much infection, PPRO in preterm labor or chorioamnionitis from a stitch, which we have all of us have seen this. But definitely, if when she delivers, either through a stitch that hasn't been taken out, a stitch that has been partially taken out, or the cicatrization that occurs from the stitch on the cervix, they have an increased incidence of tears. And once she's on a stitch, either she's upside down on the bed with a bedpan and not doing anything else. So her loss of economic function and man days is terrific. So I'm now going to go back 5 years. So what did we have to offer the woman who was at risk? We're not yet putting the stitch. So did we give her vaginal micronized progesterone? Did we give her 17 hydroxyprogesterone? I put that in red because that's exactly what we used to do. We don't do it anymore. And right from 16 weeks, right up till 36 weeks, she got a shot. Did we put in a prophylactic cerclage? No. So those days we thought, and even now today we think that you either give prophylactic vaginal progesterone or a cerclage to any woman who has both. That is, she must have a positive history and a short cervix. You're fine. So when both these are there, don't give both. That is, don't give her progesterone and the cerclage, give her either, the cerclage is better. Especially when the cervix is short, the cerclage is better. But they are not really recommended for twins and multiples who are otherwise normal, even if it's a triplet, because it is associated with a twofold increase in preterm deliveries per se. So when they have both, the cerclages actually reduce pre-viable births. 6.1% was the pre-viable birth when the stitch was put in versus 14 when it was not. Perinatal death also improved, 8.3 versus 16%. But at the end of it, they did not actually prevent preterm births less than 33 weeks. They all delivered a little bit more earlier. So 32 versus 42%, which is actually when the cervical length that was considered was 1.5 centimeters. So we slowly seem to be going away from progesterone and away from the short cervix for cerclages. So why did we give up on 17 hydroxyprogesterone, or what we call Proluton? Everyone is familiar with that word. In 2023, the US FDA actually took away Makina or Proluton from the market. It was not really based on safety concerns. It didn't really cause much of fetal anomalies, but it was rather a lack of proven benefit in these cases. And this moving away from 17 hydroxyprogesterone was endorsed by the Society for Fetal Medicine as well. So now, do we have no history of preterm birth? Nothing. Clean history, but the cervix is less than 2.5 centimeters. Earlier on, we offered them progesterone. We offered them 17 hydroxyprogesterone. Today, I know very many of us offer them vaginal micronized progesterone. But again and again, the benefit comes only if you have a positive history. Without a positive history and purely a short cervix, that really doesn't mean much. 2023 ACOG really confirmed this, that vaginal progesterone has not shown to be effective in women with a prior history of preterm birth without a short cervix. And so these women need surveillance. But the NICE said, go ahead and give it. So those of you who are giving it, please continue. These are two old trials, the Optimum in 2016 and the Progress a little later. They all told us that vaginal progesterone, when given without and with prior risk factors but no short cervix, really didn't decrease. Any decrease in preterm birth was not seen, and composite neonatal outcomes also did not improve. So is it time for us to progress beyond progesterone? So let's say you have a short cervix, you have a positive history, or you have a history indicated cerclage. Which cerclage are you going to use? When are you going to put it? How are you going to put it? And when are you going to remove it? So the aim here, I think now a large majority of us have moved away from the traditional McDonald into a Shirodkar cerclage, which is the right thing to do. Because the aim is to put the stitch as high as is possible, that is above the level of the Menon rods. So the guidelines will tell you that you respect the surgeon's choice, but the most physiological amongst them is the Shirodkar. Shirodkar is not really difficult to do. It only means under anesthesia, infiltrate a little bit of saline or not adrenaline because she's pregnant, but you can put in vasopressin into the anterior vaginal wall. Just open it up, push the bladder as you would do for a vaginal hysterectomy. Take a stitch there. You can use a suture carrier and put both into the posterior side and tie the knot posteriorly. So Shirodkar is easy, not very difficult. Once you start doing it, it becomes very much easier. Always you wonder in pregnancy, should I open up? Should I just put the McDonald's? The McDonald is not physiological. It is much below the level of the internal os, whereas the Shirodkar is at the level of the internal os. So previously failed vaginal procedures are probably better managed with an abdominal route. When you put the cervicoisthmic cerclage through a avascular area and the broad ligament and tie it, you can either do it abdominally by laparoscopy, or if you're not comfortable with the laparoscopy, by laparotomy. But you can even put it preconceptionally, really doesn't make a difference. And for you, the study is the Maverick study, which tells you that there is a benefit from putting it abdominally. Remove it at 36, 37 weeks, or if she gets into labor with rupture membranes. So the Maverick really told us, it randomized abdominal versus vaginal cerclage, and vaginally both, they studied both the high as well as the low, that is both the Shirodkars as well as the McDonald's. Less than 14 weeks. Births less than 32 weeks were much lower when an abdominal cerclage was put when compared to the low vaginal. That initial study did not really say that Shirodkar was better than McDonald's, but when a retrospective analysis of many cohorts were taken, higher the placement, better the outcome. So as we stand today, the Shirodkar is better. But that doesn't mean you don't learn the McDonald, because if you have to do an emergency cerclage, it's only the McDonald that you're going to use. So you must know both. What suture material are you going to use? I know very many of us, there was a time beyond when we used to use nylon. Look at the number of knots you're going to have, which is going to be exposed. So Mercelin tape, the choice is left to the surgeon, but Mercelin tape will do well. It's expensive. Now you have the braided ones that come, which is the True Bond, Eti Bond. All of them are good. They have needles on either side, so it's easy to put the Shirodkar. You don't need tocolysis, you don't need progesterone. Once the stitch and paste, she doesn't need bed rest, she doesn't need her foot end elevated, no long term antibiotic. And they say no post stitch length surveillance, that is after you've put in the stitch. But I always think, suppose I know this woman is likely to deliver before 34 weeks, if it is short. In that case, if I look at the stitch or the length of the cervix after I've put in my stitch, let's say from 28 weeks, at least I can time my steroid better. So sometimes I really do, but studies have tell you no stitch surveillance. I've already told you that sometimes you may need to put in the stitch even after 23, 24 weeks. Emergency cerclages to be individualized. Everybody will tell you it is a procedure with no proven benefit, but remember there is very little data on this. But you must remember that advanced cervical dilatation, you can't see the cervix at all. The membranes are much below the external os. Your chances of failure are extremely high. We all know what are the contraindications to cerclage. We're not going to put it if there's active labor, chorioamnionitis. But I have one thing to say. Very often, especially in large public hospitals, the resident would have looked at the cervix as, madam, there's white discharge. What they really are looking at is the mucoid white kind of discharge, or the translucent discharge that comes out of the os when the os is open. So unless you're really sure that it is candidiasis, wait, but otherwise put in the stitch. Do we need to do this is my last slide. Do we need to do an amniocentesis prior to cerclage to rule out infection and then put in the stitch? No, you're wasting important time. In an emergency cerclage, should you reduce the amnion a bit, take in a little bit of fluid and then put it? No. Bed rest, most of it is no. Bed rest is no. Tocolysis is no. Are you going to use Mercelin tape, whereas polyester braided material? You make that choice depending on what you have available to you and what is cheaper for you. Mercelin is quite expensive. Post stitch length, by and large, you don't really look at it, but as I suggested, if you have a ultrasound indicated cerclage and you want to time your steroid, you may. In a rupture membrane, do you leave the stitch alone or do you take it off? Studies tell you don't keep it for more than 48 hours, just till you give the steroid, don't keep it beyond that. What if she has an IUD later and you've placed an abdominal stitch? You may need to go in abdominally and take the baby out. Does history really tell you that there is painless cervical dilatation, so I need to put it? No. Painless cervical dilatation only occurs from 3 to 4 till about 3 to 4 centimeters. After that, contractions become painful. So there also you have nothing to say. Thank you very much. I think we'll take the questions.
Thank you, ma'am. You may please take your seat on the stage as we are moving on to the discussion with the experts.